Today we will showcase another segment of our Ideas That Work series. We are at Washington Adventist Hospital to discuss their ED U-turn conversion program, and will feature several members of their team.
Well, the program was initiated about 3 years ago, and it was really a joint venture by the emergency department and our population health team. And there was a clear recognition that we had many patients who frequented the emergency department, perhaps unnecessarily. So as the global budget in Maryland came into being, that led the hospital to look at supplying resources for patients who come to the emergency department for crisis intervention and then are sent back out into an environment in which does not support them, and they end up in crisis again. And it may be for medical reasons, psychosocial reasons, financial reasons, but nevertheless, there was no support for them once they left the emergency department. Initiating the population health department, developing that department, and providing resources to that department allowed us to partner with them and look at why were these people coming in so frequently, and what could we do to stabilize their environment, their medical condition as an outpatient to prevent them from developing crisis and coming back.
We at Washington Adventist and Adventist HealthCare broadly invested in healthcare transitions staff. So in terms of this program, what that means is we've hired a nurse, Marshall, to work in the ED alongside a social worker and a community health worker. They work very closely with the ED staff to identify those patients who may not need to be admitted, but do need that support that Dr. Nordeman alluded to. Helping to discharge plan for those patients, ensure that once they leave the doors of the ED, that they have what they need. Beyond the support that my staff provide within the ED in conjunction with the ED nurses and physicians, we have a nurse transitional care manager who can follow up, do home visits for those patients who need PCP appointments, specialty appointments, transportation to appointments, connection to other community resources.
Well, I wasn't here when the program was implemented, but I can tell you what we do to identify patients that are in need, which is we meet bi-monthly as a multidisciplinary committee, and we have a list of patients that have the highest number of ED visits for the month, usually select a couple of those, and then additionally we get input from other physicians who may have identified a patient who's coming to the ER frequently during that month and have identified a need that maybe would be best served by our committee.
Some of the challenges that we identified initially was the resources that we needed to help these patients. Some individuals who were high utilizers were because of their medications. They're unable to fill their prescriptions because they have to decide whether, am I going to buy groceries today or am I going to buy my medication for hypertension? So again, finding the resources and finding the finance to follow up with these patients. And the population health was able to provide us with not only some financial resources, but also outside resources like the nurses and the case management that are involved with that. We've also partnered with our EMS system, both from Montgomery County and PG County, to help us follow through with patients and follow up with home visits too.
Once we identify an individual that can use our resources, I initially I go over the clinicals to see if that individual would need external resources from a medical standpoint, like a PCP appointment, specialty appointment, care coordination that would in detail telehealth if they have the chronic health issues such as hypertension, CHF, diabetes. I do the initial teaching in regards to those subject matters, and then I refer them to the transitional care manager or community health worker who would then kind of take on the external care coordination role as I am based out of the emergency room.
Our team has really diversified over time as we've realized some of these needs may not just be that they need their medication filled, or they need to connect about their weight for their CHF. When we started, it was population health, an emergency physician, an emergency nurse, and that was it.
That was it.
And now we have our psychiatric team as part of this, social service, population health, EMS.
We have a homeless liaison group that comes.
We have drug and alcohol addiction and management. And so I think the strength of our team and the success of our team is that we look at that particular patient and their unique needs. And then we bring into the team the resources to help us meet that need.
And the end result is that each patient gets a care plan that we develop for them, which consists of, when this patient comes to the emergency room, this is what we should be doing for them, and has literally a list of contact this case manager at this phone number. This patient has this need, address that, because all the emergency physicians don't go to all of these meetings, so they might not have all of this complex information, and we disseminate it to everybody through these care plans, which can be accessed through our electronic health record.
The greatest benefit of this program is to our patient. So we started this to meet our need, and our need was to unburden the system of visits that didn't need to occur. But the end result is all of these patients have a better life. They're in better health. They have better psychosocial support. And really, that has been the greatest benefit.